All right, we might get started. So my name is Siva Gananatha. I'm the clinical director of the ACT Audit of Surgical Mortality. Thanks everyone for joining us today on the webinar, which is the topic is interhospital transfers, a regional and referring hospital perspective. So before I start, I'd like to acknowledge the traditional owners of the land that we are all on today and extend my respect to elders past, present, and emerging. So the reason why we've chosen interhospital transfer, this is a second webinar that we've had on the same topic, mainly because interhospital transfer deaths among interhospital transferred patients is a significant component of mortality in the ACT. As you can see that around a third of the patients are patients who have transferred from interstate. And if you look at the different specialties, neurosurgery, majority of the patients are interhospital transferred patients. So it's a really important component of our surgical care and mortality. So that's the reason why we are having this topic. And this time we want to look at it from a regional perspective and from surgeons from regional hospitals as well as hospitals who are transferring patients, or from a transferring patients point of view. So the program today is we've got Dr. Sun Lau. He's a upper GI HPB surgeon, and he's in a unique position because he's just recently worked in Bega Base Hospital, and so he's got a unique perspective where of a recent surgeon who's worked in both metropolitan receiving end and a regional referring hospital. And we got two presenters, Adrian Fernandez, who's a senior general surgeon in Bega Hospital, and Dr. Frank Piccineri, who's the clinical director of North Canberra Hospital, which is even though it's a hospital within the ACT, it's a significant component of patients or of transferred patients. So I'll hand this over to Sun to chair the session.
Thanks, Siva. You said everything I was going to say, so that's good.
Oh.
Just housekeeping things, like there's lots of people on the meeting now, which is excellent to see. We're going to have a bit of discussion sort of after each talk and maybe at the end as well. So if you have any questions, you can type them in the chat, or later on you can raise your hand, you can ask them live. So just save your questions to the end of each talk and we'll go through it. But if they come up along the way, I'll sort of moderate that. But otherwise, I think Adrian's going to speak first. So thanks, Adrian. He's a general surgeon, special interest in colorectal surgery, working in Bega as well as Cooma and Canberra. So thanks, Adrian.
All right, thanks for joining us, everyone. I am a general and colorectal surgeon based in the far south coast, New South Wales, for more than 10 years now. Next slide, please. And today's talk really is maybe born out from this report that ACTASM had prepared, looking at transfers from southern New South Wales to the ACT from 2013 to 2023 inclusive. So 11 years worth of data. Next, please. I have no conflicts of interest. Next, please. So I thought I'd start off really with this stat. I found it to be quite impactful. This being interhospital transfers is an independent risk factor for increased mortality. Next, please. And there is quite a bit of literature to support this. Next, please. This is a Western Australian study, Fiona Stanley Hospital, and it looked at hip fractures from patients who presented primarily at the Index Hospital and patients who required a transfer. And they found that patients who received, so the gold standard for hip fractures is 48 hours. And despite patients who were transferred and who did receive their surgery within 48 hours, they found that interhospital transfer, regardless of time to surgery, had an increased mortality. Next, please. And again, this is a study from Switzerland, published 2021 World Journal of Surgery, and it looked again at general surgery emergencies. Again, primary presentations to the hospital and transfers. They had 3 cohorts. Again, all general surgery abdominal emergencies. And again, they found evidence that an interhospital transfer, especially for patients with potential bowel ischemia, was an independent predictor for mortality. Next, please. So I thought I'd just give you an overview of today's talk. Click again, please. And we sort of finished the introduction. I'm going to go through a little bit of geography for those who don't know Southern New South Wales Health Service. Look at some of the mortality data in relation to transfers, some decision making in relation to transfers, delays, and maybe some strategies. Southern New South Wales is right at the bottom in green, and the ACT is in the middle. Our population for Southern is about a little more than 200,000, and I believe ACT has about 450,000. Next, please. That's just an aerial view of Southeast Regional Hospital. And the next click will just to let you know that this is dairy farming.
Okay.
Yep. Next, please. This is just some data in relation to Southern New South Wales. In their year in review, 2022-23, about 2,500 emergency surgical procedures were performed. And in contrast, next click, please. Canberra Health Service was showing about 235 emergency surgery procedures in a week. This is Southern New South Wales. Again, in green is the coastal network that Bega is part of. And the orange bit is the inland network. So there are 2 main hospitals within this, north being Goulburn and south being Bega. There are other smaller hospitals, and somewhere in between is Moruya. And you'll see that Canberra is right in the middle. Next, please. This is just a little graphic about, and if you just click that, Siva, please. That shows it takes about 3 hours by road between Bega and Canberra. Next, please. We are dependent on the ambulance service, so Ambulance New South Wales and CareFlight. India, again, it proved to be really difficult to find the denominator for interhospital transfers. But looking through what was available, for example, a report by NSW Ambulance Service showed that they were involved in transferring about 87,000 patients. This is throughout New South Wales to alternate care pathways. CareFlight was involved again over a 12-month period for Eastern New South Wales, so along the seaboard, more close to 2,000 patients. Next, please. So, looking at some New South Wales data, on average, about 7.3% of New South Wales admissions. This is within public hospitals. So all New South Wales acute care hospitals, about 7.3% were associated with transfers. Next, please. And this same group published a year later, just emphasizing the fact that the data for transfers is inaccurate. There are a lot of gaps, and it proved to be quite difficult to find accurate data in relation to transfers out of our hospital, for example, to really drill down within southern New South Wales. And they found, again, over 2 years, looking at 121 acute care hospitals in New South Wales, that the accuracy for transfer out was 87%. Accuracy for transfers in was only 65%. So, I do feel that there is it is difficult to find an accurate denominator. Next, please. Coming back to the ACTASM report. So this is 2013 to December 2023 inclusive, so 11 years. There were 1,188 cases that completed the audit process, and of which there were about 1/3 required a transfer to TCH. And from Southern itself, approximately 12.4% of all cases notified to ACTASM were transfers. Next, please. Next, please. So, and again, taking a bit more data from this report, what I'd like to highlight really is delays. And you'll see that, between 10 and 20% of these cases was found to have a delay. There was more than close to 90% where information was found to be sufficient in relation to the transfer, level of care was appropriate, and the transfer itself was appropriate in at least 90% I think. So what I thought I'd like to just draw some attention and pay a bit more focus on was really in delays in transfer. Next, please. And again, looking at CHASM, so New South Wales, their data trend for 2015 to 2020, you can see highlighted there in orange, 10.2% of patients transferred pre-op had a delay in transfer. So, it sort of is in line with the delays between Southern and ACT. Next, please. Drilling down a little bit, again, from an annual report with ACTASM, there were, again, a little more than 1/3 of patients were transferred, and delays amounted to 8.3%. Next, please. So there are two components that I just like to talk about. We know that transfers are inevitable in our healthcare based on the fact that, Australia is so wide and a lot of services or high-level care services are concentrated within the city. So we know that transfers are going to happen. So what triggers a transfer is a question I thought it's quite easy to answer. But the second question as to, why a delay happens, I think is still very opaque. So, what triggers a transfer? So when the hospital does not have appropriate resources to best meet patient needs, right? So, for example, we don't have a vascular surgeon at our hospital. Other specialty services, someone who needs an urgent ERCP for an obstructed biliary system. As an example, interventional imaging, pelvic abscess in a septic patient that needs that might be better served with radiology, lack of intensive care beds, and I've just made in bold non-clinical, sometimes a breakdown in communication between the patients and health services. So the perception that they may not be getting all the care that they should or could, although that may not always be the case, might sometimes trigger a transfer. Next, please. So what I found in preparing for this was that with trauma, there are well-established protocols, and that the likelihood of a delay in transferring a trauma patient is much less than in relation to emergency general surgery. So it's less formalized for acute non-critical patients who are outside the urgent trauma retrieval. Next, please. And just click again, please. So this is a paper that just confirms that it came out of a regional hospital or health service in Victoria, and they found that transfers were less likely to be delayed in trauma patients when compared with urgent non-trauma patients. Next, please. So the Adelaide group has done quite a bit of work on inter-hospital transfer delays, and they were looking at trying to predict if a delay was going to impact on mortality. So a lot of this data again comes from the Australian and New Zealand audit of surgical mortality. And what I found striking was, so certainly there are modifiable and non-modifiable predictors. For example, gender of a patient, comorbidities, were not modifiable, but modifiable predictors included an inadequate clinical assessment where the odds ratio was close to 50. So in other words, if there was an inadequate clinical assessment, more than likely this was going to predict an inter-hospital transfer delay. Other things included poor communication, multiple transfers. Things like age, lack of beds, after-hours transfers did not predict transfer delays. Next, please. And again, please. Again, another paper coming out in relation to what are the factors influencing inter-hospital transfer delays. So they looked at six, or they found 6 retrospective studies and presented some of their findings in relation to this. All of them were retrospective. There was quite a degree of bias. But essentially a lack of consultant surgeon input. They found after-hours transfer, need of intensive care beds, documentation, all of these may have a role in inter-hospital transfer delays. Next, please. And again, please. So their conclusion was we needed better data to analyze. And it should include things like the times of admission, a diagnosis, when was the decision to transfer a patient made, how difficult was it to get acceptance, departure, arrival at receiving hospital, and anything that took place in between. Next, please. So what I'd like to say is that we know what triggers a transfer. The overriding theme in relation to delays in transfer, so things that are under our control as surgeons, among the bits of literature that I looked through, the recurring themes were for us to intervene early, and especially a clinical assessment. And it needs to be senior clinician input. Communication, and the other thing that I think we can consider would be the implementation of a more structured pathway. Next, please. In 2019, there was a seminar in relation to the Queensland audit of surgical mortality. And some of the highlights included an awareness of facility capability, a quick surgical review, or again, talking about senior surgical staff involvement, pathology, radiology, communication. I mentioned clinical pathways, and just trying to have a more structured referral process. Next, please. I put this slide in because I found it quite useful. This is a study from the UK in relation to trying to reduce mortality after an emergency laparotomy, and they found good evidence to have a standardized care bundle, and it included parameters to identify patients who present to the emergency department, who fit certain criteria, and especially in terms of the deteriorating patient. And they found that there was a significant reduction in the risk of death following emergency laparotomy. Next, please. And again, I found this recommendation from ACTASM to be again highlighting key messages. This being improved communication between the referring consultant and the receiving consultant, collaboration between hospitals to identify these deteriorating patients, make the decision to transfer early, and it has to be at a senior level. I believe there was a talk previously on futile transfers, but I thought that these recommendations again just highlight all the other evidence as to how we know that delays are going to happen, but how can we minimize these delays? Next, please.
Thanks, Adrian. If there are any questions, put them in the chat. While we're waiting, Adrian, I thought it was really excellent. It's highlighted a lot of the issues that we see from time to time and backed it up with some of the literature about all that, which I think is really nice. I guess on a practical level, my observation is that a lot of the urgent transfers happen, right? Like if someone's really sick, they'll go, right? Yeah. The ones that are difficult are the ones where it's really, really urgent or it's not that urgent, right? Because if they're really, really urgent, the question is, and the other question that comes up time and time again is like, should they have something before they go to account for the delays, right? So why don't we look at that a little bit? What are your thoughts about that?
I am a believer of that model soon, because I think if we can do something locally, I prefer to do it. And then and the decision to do that, I believe, again needs to be in consultation with the tertiary center. That we are all in agreement that someone with ischemic bowel who's otherwise unstable, for example, or just thinking at the top of my head, that why don't we just why don't we do this here? And if we run into trouble and we're not able to look after the patient, is when he or she needs to be retrieved. Similarly, for example, someone with so common things, commonly, so a perforated diverticulitis, who is sick and septic. I mean, as a regional hospital, my preference is that we should be able to do these things. I guess it becomes difficult if it's a specialty that I personally am not comfortable doing. So something an acute vascular problem, apart from acute limb ischemia, if we have a Fogarty's catheter to try and retrieve an embolus. And I just want to add soon that our intensive care capability has improved in the last few years. We weren't able to ventilate a patient for more than 24 hours previously, but we can do so now. We do have intensivists around the clock in Bega presently. So, we have improved in that sense.
Yeah. I think what you highlighted is the collaboration is the key, right? So if you've got a patient who you think needs urgent surgery, but you're not sure that your hospital will be able to support them after that, I think the key is that you have a conversation with the team that you expect is going to take them after, right? And then having been on the other end of it, almost always we'll say, do damage control and we'll take them from theatre, and that's perfectly fine.
Yeah.
Frank's got his hand up.
So oh yeah, go for it, Frank.
Yeah, so like Steve, I've been doing this for a lot of years, and I certainly understand Adrian's constraints there. So most of our referrals from the southern area do come from Moruya, Goulburn, Cooma and Bega and Queanbeyan. And sort of my experience with a small hospital like Moruya is that because they don't have an HDU, they are totally constrained with what they can do after hours, no matter how much skill the surgeon has. If the patient's ASA3 or above, that hospital cannot take those patients post-theatre. So you often get transfers that could have been done locally. On the other side of that coin, the new hospital at Moruya is going to have an HDU. So we look forward to that.
There's a question in the chat from Rebecca. In patients who are delayed, is there evidence of a change in plan, say for local management, or of poorer outcome in delayed patients? See if we can answer that.
Sorry, was the first part of the question, is there a change in plan if there's a delay?
Yeah.
So in other words, while the patient's waiting for transfer, the clinical situation might change, where either the transfer will become futile or it declares itself, or or something. I think that's what Rebecca is.
I think that's a very valid question. I think because it's evolving, it can evolve quite quickly, someone's clinical presentation, and delays can be for a few hours. So it would mean close, a close assessment of, and a close and repeated assessment of our patients, and not just sign off and walk away, especially if there's going to be a significant delay. We've had patients where it's been difficult to transfer because of the weather. So during winter, fixed wing aircraft can't land, nor can a helicopter. There's snow on the mountain, and we might have to look after this patient overnight until it's daylight that allows a helicopter to land. So I would say that again, it needs to be in consultation with the tertiary center that, look, my patient is going downhill. I don't believe it's going to be futile for me to take this patient to theater to do damage control. And I think a shared decision making is always helpful.
And the thing is that, Adrian, Bega is the best resourced regional hospital in our area.
Yes.
So of all the patients that we get, Bega, Maria, Crookwell, Kuma, I think Bega is the most best resource. So if it's cannot be done in Bega, no other hospitals around the region will be able to take them. But I like your idea of a pathway, because we definitely can have a pathway with, say, perforated artery or septic patients.
Yeah.
But I think I don't know. Frank might know this, because of interjurisdictional responsibility, whether ACT hospitals will take responsibility for expediting this pathway.
Well, actually, I was at a meeting just before this meeting discussing this sort of stuff. Yes, the minister has given that undertaking this week, that anybody that needs healthcare in our region will not be turned away. So that basically gives us the green light to expedite this sort of stuff.
So I think that's a good suggestion, Adrian, because we definitely can organize some pathways and expedite early recognition of these patients that would ultimately need a transfer anyway.
Yeah.
Okay. There's some other questions in the thing, but we might leave more discussion for later on. So why don't we move on to Dr. Visionary's talk?
Okay, thanks for the invite. And actually, I really like to compliment Adrian on the quality of his talk and the amount of work he did for preparation. I'm just going to focus more on the REDCap data. So I'm now currently working as a clinical director of surgery at North Canberra Hospital. Prior to that, I was a similar position at the Canberra Hospital. The North Canberra Hospital is the second largest hospital in the ACT. It's the second public hospital. There's approximately 240 beds. It's a level 4 hospital located in Bruce, ACT. That's the north side of the lake. And it previously was known as Calvary Public Hospital, owned by the Little Company of Mary, providing a contracted public service to the people of the ACT. As of a year and a half ago, it was absorbed into the Canberra Health Services, and it's been renamed North Canberra Hospital. It is now a 100% public hospital. Hospital is on trauma bypass. There is no acute neurosurgery, cardiac or vascular or plastics on-site staff. The emergency department is quite busy. It accepts all other acute conditions. Occasionally, sometimes acute traumas will stop there to aid in resuscitation of a very ill patient, but the rule of thumb usually is that they go directly to the Canberra Hospital. There is an emergency theatre which does not operate 24 hours a day, but it's mainly services acute general surgery, gynecology, obstetrics, and during the day gastroenterology. There is no after-hours gastroenterology on-call service. So if somebody comes in during the day with a bleeding duodenal ulcer, they may get a gastroenterology intervention. Next slide, thanks. We also have a 24-hour on-site anaesthetic and ICU registrar. The general surgical registrars are on call only, but they do work into the evening before going home. We've got 3 GSET trainees, 2 unaccredited registrars and 1 fellow. There's on-call consultants in anaesthesia and ICU, as well as for general surgery. The general surgery consultants have in the past covered Canberra Hospital simultaneously. That was mainly due to staffing constraints. There's more people on the roster now, and it's also a lot busier. So there's a move to split the roster so that you're only covering one hospital at a time. It's not going to happen quickly, but we're aiming to on weekends initially. Next slide, thanks. So the case mix is about 20% emergency, and this is the typical general surgical type stuff like abscesses, appendicitis, gallbladder, bowel obstructions, intra-abdominal sepsis. This year saw us forming an ASU within our own resources, and it's covered by an acute surgical fellow that we got funding for this year, and the 2 unaccredited registrars help cover this as well. And on the basis of this ASU, we were able to show the numbers to the college, and we've now been approved for a 4th GSET registrar for next year, who will be not only the ASU registrar, but we'll be able to spread that person across all the units. Yeah, next slide, thanks. As I said, the constraints that we have are there is no 24-hour registrar cover, difficulty opening a second theatre after hours. It's certainly with the nursing staff, call extra nurses in after hours means that they will then be given the next day off, and that will affect elective surgery the next day. The huge constraint for us is there's no interventional radiology. The radiology service at the moment is basically imaging only. It's contracted out to a private company for reporting, and they do come in to do the reports, but they may as well just do it from the comfort of their own private practice rather than come in, because we don't get very much interaction with them. In addition, there has been a cultural transfer because of the excellent service at Canberra Hospital and the all these other constraints we've had at North Canberra Hospital. Next slide. So the current methodology for transfer is it's a registrar to registrar call, and then the registrars having consulted with their respective consultants if it's a split roster, if otherwise it's just one consultant. Transfers in from North Canberra to TCH will usually bypass the emergency department, and most of our transfers are directly to TCH, which is 17 kilometres away, and it's either performed by ACTAS mainly or the retrieval team. There's no helipad on site. Next slide. So the REDCap data is in the ACT, TCH receives 93.5% of all transfers. Most of the others going to North Canberra Hospital. Next slide. When you break these down, the referring hospital says, well, North Canberra Hospital is responsible for most of the referrals for TCH. And then there's a big cohort from Queanbeyan, because Queanbeyan does not have after-hours specialist cover at all. And then the regional hospitals, Cooma, Goulburn, Maruya and Yass are responsible for the other 30-odd% of those regional transfers. Next slide. Next slide, thanks. Reasons for transfer at North Canberra Hospital. The 2 big ones is surgeon preference and surgeon availability. Certainly when you're covering 2 hospitals, you don't want to spread yourself too thinly. There's very good fellow cover at the Canberra Hospital. So for those two reasons, most of the reasons put down for patient transfer is surgeon availability, surgeon preference. The other things aren't. Then the next one is specialty specific hospitals. So if you need to transfer somebody for some specialty procedure, such as a vascular patient, or a general surgical subspecialist, such as a colorectal or upper GI. Surprisingly, intervention radiology to me is pretty small, 7.7%. I expected that to be higher. And so that's the other reason, major reason for transfers. Next slide. Thanks. So, in part of discussion, so the surgeon preference or availability is due mainly to the simultaneous TCH-NCH cover. This has been on the Canberra Hospital Risk Register for the last 9 years that I can remember. There is a need to split the roster. but this bears tremendous resource implications, and I think it's going to happen gradually. Most general surgical cases can be done at North Canberra Hospital, but there are some constraints. There's the lack of 24-hour registrar cover. There's no full-day dedicated emergency theatre, and there is no after-hours fellow roster. Next slide. And it is a after-hours emergency general surgery in the ACT is quite a busy area now. Back to the interventional radiology, as I said, 7.7 of transfers from North Canberra to Canberra Hospital for interventions. I've already talked about the medical imaging, and there is a big push, mainly from North Canberra Hospital, to integrate our medical imaging with that at TCH, which has got quite a broad medical imaging base. And having an on-site intervention service not only will help with reducing the number of patients requiring transfer for percutaneous drainage, for example, but also we have we're the main breast centre in the ACT, and we do not have a tumour localisation service available on site. Patients have to go off site for their localisation prior to surgery. Next slide. Oh, last slide. Thank you. The way forward is by strengthening emergency surgery at North Canberra Hospital, which we think will happen with all those things I've mentioned in the previous slides. There will be less transfers. There will be an improvement to the length of stay. And the other thing that we don't really do well is load balance between the two hospitals. North Canberra Hospital does a lot of routine general surgery and fairly well. There is an opportunity to transfer in both directions. For example, if patients are on the acute waiting list for a gallbladder at North Canberra Hospital and the wait's quite long, and there's space at North Canberra Hospital, at TCH, if they've been waiting for quite a while, and there's space at North Canberra, we should be able to transfer in the opposite direction. This is going to be much easier next year when we'll have full day operating in the emergency theatre. We've been trying to get that for quite a while, and the funding's not been available, and it's been promised to us for next year. The other option is to increase services at Queanbeyan Hospital, which has got two really nice operating theatres. Okay, I think that's all I want to say, and I think we should just open this for discussion now. Son?
Yeah, thanks, Frank. It's really interesting, perspective, and as you know, I try and do everything at North Canberra, try and facilitate that, and I can count on one hand how many times I've transferred a patient, but I can say that hopefully that's going to reduce with time. So there's a couple of questions in the chat. One is from Phil. It's about this is sort of going back to that topic we talked about, whether to operate locally first, or transfer the patient for an operation. He's highlighted that previously in critical care. Some people have mentioned that, if you operate, the anaesthetic decreases their sympathetic compensation, and so possibly this is less desirable before a transfer. I don't know if there's anyone really equipped to answer that on a detailed level, but I guess open to your thoughts, Frank and Adrian. What do you think about that? Should we definitely be operating first, or should we try and send them over to have surgery urgently? I mean, just my thoughts are, in reality, transfers take longer than you think, and it's pretty unusual to be able to get a patient from another hospital to an emergency operating theatre at a major centre within a timely manner. And so in general, that takes a long time, and so often you miss that window to intervene. So I don't know, what do you guys think about
that? I think it's almost like, from I can't answer in detail about the critical care aspect of it, so the compensation or uncompensation or decompensation. But I really am a strong believer that, if a patient needs to be transferred, but if in consultation with the tertiary hospital, that it's probably, well, it is in a patient's better interest to have surgery or damage control surgery, then I think, you know, I think we should just do that. Especially if there's going to be a substantial delay.
Yeah, I agree. Anyway, maybe a thought to ask your next intensive care colleague when you see them about that. There's another question here about anesthetics. So, yes, Frank?
I just on just in the North Canberra experience or situation. Look, you've got the same surgeon operating across both campuses, same registrars. I think what's more relevant for us is really load balancing. If we can balance our loads better between the two hospitals, then I think we'll get better outcomes. I don't think we should be transferring everything from one hospital to the other.
Yeah.
Because
I've tried that reverse transfer a couple of times, Frank. So I was on at TCH. I tried to send a patient to North Canberra, and I think what happens is you end up sending them and they don't have a theatre time, and so they end up waiting even longer. But
yeah, so that's the thing. It requires a bit of coordination, but you've got one hospital that's working well above its capacity, another one that's not reaching its capacity. So we need to find the balance, and I think that's our main aim we should be doing at the moment, because we've got the same level of
Rebecca's
expertise.
got your hand up. Go for it. Yeah.
What I was going to say is that I do think that in Canberra, especially if we have the split rosters, that there are lots of patients that can be managed anywhere by anybody. And then there's another group of patients who, in the hands of a surgeon with subspecialist expertise, will get a different operation. For example, someone with a large bowel obstruction who might get a primary join with one surgeon and a Hartmann's with another. And that has significant implications for the patient. And I do think that we shouldn't set up a system where a small hospital has different preferences and choices within the same community. It's different if you've got a long transfer time, but if we are all working together, we should really be able to put patients in the position or with the surgeon that's going to give them the actual best outcome for the pathology that they've got. For example, if the patient has cholecystolithiasis and the ERCP has been unsuccessful, that patient should clearly go to USUN or SIVA and not be having their lap chole with me. I think that we just need to, I think we do need to in Canberra be mindful of that.
Yeah. And it's about communication, isn't it? And like figuring out case by case where that falls. Like you can't have a single rule for everybody. And it's about the time involved and the individual circumstances and all of that, all those points to say. I just wanted to move to another question from the chat. Dr. Khan has asked us about anesthetics. So it sounds like, they have GP anesthetics. I think that's at Maria, where they're maybe conservative with their approach and restrictive about doing patients locally. Well, I mean, what do we think about that? Like, I guess, of course, Maria is a bit limited about sometimes what can happen there. And Dr. Khan, if you want to elaborate, feel free, raise your hand, we can unmute you. But I guess, Adrian, do you have any thoughts about how you deal with those situations in Bega?
I don't think we have a choice, really. It's dictated by, its governance, and that, for example, a GP anaesthetist, and not meaning to speak out of turn here, but that a GP anaesthetist can only do X, Y, and Z, and nothing more than that. I'll give you something quite simple. It's not an emergency, but 2 or 3 weeks ago, we had, I think, a 6-year-old with a cut lip that needed a general anesthetic to repair, but couldn't have anesthesia in our hospital because the on-call was the GP anaesthetist, and so had to travel to Canberra for that. I mean, the surgery was simple, but so it's just governance. We'll be butting our heads trying to get something done. I totally understand the constraints that Moruya, although well serviced by surgeons, but restrictions as to what they can do.
And was the transfer smooth for that patient? Was it quick and easy?
I'm not sure really. It was a cold case, so we were willing to do it, but yeah, we didn't have an anaesthetist that night, so had to go.
Yeah, sure. Yeah, makes sense. And certainly that's the other extreme, isn't it? Like those cases where it's sort of urgent, they can't be discharged, or maybe they can be discharged, but it's not very urgent. And so you end up with these patients who wait around for quite a long time to be transferred to another hospital. And certainly that's universal, right? Like I've seen that in many places. And I think there's something I've observed anyway, is that often these patients maybe get a bit forgotten once they've been accepted for transfer, because their care seems to stagnate, and you think every day they're going to just go, they're going to go, when are they going to go? And I wonder, do you have any thoughts about that, Frank, as well, about patients who are waiting for transfer? What should be happening with them? Should we just wait and wait and wait, or should we try and do something?
Well, I think most of the time we end up trying to advocate for the patient as much as possible. It's a real bed management issue, isn't it? And that's where we probably should talk about these reverse transfers. You know, I'll give you my patient, I'll take one of yours. And we've done that in the past, but we haven't done enough. The other thing is in the past, we've had trouble with the ambulance service because transfers are often a lower priority than the acute emergencies. So I can't speak for them. I don't know what the situation is now, if the arrangements change, but that's been a problem in the past. So if you look at the reasons for delays, I think there's a transport reason and then bed availability. So by doing that swap, we can deal with the bed availability issue. And I don't think we explore that enough.
So, Frank, I think North Canberra is in a unique situation because effectively it's you said it's level 4. It does have an ICU, is well staffed. It can be ventilated for days if required. There has been, when I started in 2008 and to 2010, I used to do Whipple's and major surgery down there. My thoughts are that the biggest obstacle is availability of emergency theatre. You can sometimes, the emergency theatre, there's been days when it starts at 5 and finishes at 8 because they don't want to do any cases after that. That's the biggest obstacle. Second is interventional radiology, like you mentioned, but most patients can be managed without interventional radiology. The other thing is, over time, the theatre staff have become de-skilled because they've really not been, and it does take a bit of effort to start upskilling, which is possible. But I think the biggest, if you had to tackle one thing in North Canberra, is availability of emergency theatre.
Sure.
And yes, there's 2 rosters in ACT, but if you think about it, during the weekdays, a surgeon covers North Canberra alone and does not cover ASU. So it's only split single roster at night and weekends, but during the day there's only individual surgeon covering each hospitals. So I think if you can enact one thing, that's actually availability of 24-hour emergency theatre. And once you start doing emergencies, I think there will be a role to have on-site surgical registrars as well. So that's and so ICU is there. So I don't think there's any problem with managing sick patients in Canberra, in North Canberra.
Yeah, I think you're absolutely spot on, Siva. So what's happening in that space is to run a 24-hour roster with registrars, we need another 2 positions. And also cover the day work. We will have one of those positions available next year, and hopefully the year after we can get the second position. And I'm going to get struck down by lightning for saying this, but politically, we've had a lot of pressure to be the premier elective surgical hospital, and I think other things have been sacrificed for that. So we could easily run an all-day theatre if we just reduce the amount of elective surgery we do. But that's sort of North Canberra Hospital's strength is elective surgery, and there's been a lot of pressure to maintain that in spite of, you know how persistent I can be, and in spite of me trying to get an all-day theatre. But I've managed to get Canberra Health Services to agree to funding an all-day theatre next year. They did say they were going to fund it from August. They've slipped it back to next year, so wait and see. But we'll just maintain it.
And the
Yeah,
other
definitely promising.
The other point, sorry to barge in soon, is that there are some hospitals without surgeons. Like, you know, we do get patients from hospitals like YAS. I think we've had a few from Crookwell, but I think we need to give priority to these patients because really some of these hospitals have experienced emergency doctors, so they are pretty good at identifying sick patients. But generally speaking, they don't have a surgeon who's assessed patients. So I think it'll be good to have a sort of because they can't have the surgery done in YAS, for example, if somebody is sick. Whereas in BIGA, they can have surgery and then get transferred post-operatively. So there should be some pathways that we should establish to try and.
So my understanding is that those hospitals, if you get a call from there and you ask for it, they get transferred through emergency because they haven't seen a surgeon. So I think that does happen.
Okay.
I guess the thought I had even while we're talking was like, why can't some of these hospitals be allocated to come to North Canberra? Like, why do they all have to go to TCH? Because actually, North Canberra, you know, if you say we're going to get an all-day emergency theatre, like there is capacity to do that.
Well,
thoughts.
So Sean, when Noel Tate moved down to the coast and was still working down there, he used to send everything to Calvary because that was his. He used to work. So if I'd be on call, he'd just send them. I'd accept patients to Calvary. But that was where, I mean, I had a say in where they were directed, but that's what I used to do.
Yeah.
So there's a couple of hands.
I just got some. I said that and I got some hands up. So I don't know, Phil or Rebecca, do you want to say something there? I'll allow your mics.
I was just going to say that I think it would be very reasonable if the surgeon on call takes the call to say, you know, that this patient sounds very appropriate to go to North Canberra. This patient should go to TCH. Maybe there can be some protocols so that it's more straightforward than just individual surgeons making the call. But one of the big problems at the moment is lack of emergency operating time at North Canberra. I think that there's not capacity for a lot of the patients who are going to TCH at the moment to have surgery at North Canberra, and due to the lack of available operating time in hours. And I actually think that the funding for the emergency theatre for next year is only 2 days a week.
Maybe a comment and a question, because I noticed there's a few people from other big centres around, and certainly my experience from last year was that we actually at both North Canberra there's limited operating, Canberra there's excellent operating availability, better than elsewhere. So I think we should keep in mind other places manage this really well. My two thoughts are that should we be having the conversation about transfers at a more senior level? At the moment, it is some of our overnight registrars and registrars that maybe are inclined or don't want to say no, but maybe we should be actually supporting our regional centres to manage these patients locally with outreach support rather than accepting all transfers. I notice that a lot of transfers probably don't need to come to a tertiary centre, albeit I do appreciate that it is difficult to do a lot of the operating with less well-resourced and assistance and etc. at the regions. And second, the question, this is more of a question for those that work at other centres and also here, should we be doing more day case transfers, especially locally, where patients can never need to be admitted to the tertiary hospital, but just have their intervention and return to their regional centre?
I guess if they're sick enough, I guess it depends on where they come from, isn't it? Like if they're sick enough to come from Bega, they're going to be sick for a while in intensive care.
Siva, I'm talking about the interventional radiology issue.
Intervention, yes, that's right.
ERCP, all of these sort of things, rather than a big, major, complex operation. We have a lot of transfers to our major centre. I'd be interested to know if there's some others from other big centres, bigger centres, what they do as well, if they have a different model.
I think ERCP universally is a bit like that. You can have day stay. I think we do that already. So they can come from North Canberra and then go back to North Canberra for ERCP.
The
And certainly
interventional
we
radiology
did
would
that.
seem to be.
Yeah, and I've done that for interventional radiology as well. But I guess it's about the coordinating of the times and things like that, and if the patient is likely to need repeat procedures and suppose like that. But certainly I know like the precedent, like previously, like Liverpool used to treat Fairfield patients on a day case basis for ERCP. And so it's certainly possible. I guess it just needs a bit more organizing and all that kind of thing. But yeah, certainly an idea, certainly something we could do to help with beds and things like that.
Is there somebody else's hands up? Okay.
Yeah. So it's just on Phil's point about transferring as a day case for interventional procedures. I think one of the major troubles with that is that who takes care of the patient while they're there. And I could imagine that radiology won't be thrilled with having a potentially sick patient just sitting in their sort of recovery area without a clinician or a team that's responsible for them.
Marty, the previous model that we've used, I mean, the model we used at Liverpool last year is just the usual team. So if it was a general surgical intervention like a pelvic abscess, the general surgical team would be nominally responsible for them if they got sick at that hospital, and then they return. It's just the difference is they don't give away the bed at the transferring hospital, so they can return, and it facilitates movement. And for a small centre like North Canberra, where an interventional radiology service is going to be difficult to set up, it actually obviates the need to have a major interventional service that, you know, with on-table fluoroscopy and CT and combined settings and expensive equipment, where you can just, a transfer is actually more practical in that setting.
We've got a question in the chat from Sergey about the fellow position at Calvary, and how does it help with the ASU and the emergency cases? I'll open this to Frank as well and Rebecca, but from my point of view, yes, it does help. Like you've got someone on the ground every day who can sort out emergency surgery. I guess like we've talked about, the limiting thing here is actually the emergency time. So you've always got a fellow who can do things, but not necessarily the time to do that. But I think it does help having the fellow around because it makes it possible for consultants not to always be there and on call.
So it also makes it possible to do more complex operating there with a consultant and fellow. Yeah.
The feedback I've been given is that having a fellow has been fantastic. It's the consultants feel comfortable having the fellow look after their patients. The fellow goes around with the unaccredited registrars in the morning and checks every single emergency patient and has a plan for them. So it's a small setup, but it works really well.
And the other issue is that prior to the fellow, the seniority of the registrar has been quite variable. There's been years then we've had just set ones and set twos, and you wouldn't want to do anything major with very junior registrars. So I think the seniority has varied over the years. And I think having a fellow gives you a consistent seniority that you can do most things if you wanted to.
I think it's also good from the patient perspective because there's often been the problem at North Canberra where there is sort of the handover of patients from one consultant to the other is not always consistent. Some patients are handed over, some are kept. And I think from the patient perspective, it's been useful having that sort of continuity.
Thanks, everyone. Is there any other questions or comments before we wrap up? Well, I think this has been really productive. You know, a bit stimulate discussion, think about other thoughts. Adrian, we certainly can work on some pathways to help with regional centres and lots of thoughts about how to manage what we can do in North Canberra and TCH and transfers in and out. And I think the recurring theme is always communication, isn't it? And so talking to each other about these things to make sure that, you know, everybody knows what's going on and communicating the urgency. And it's never the same if you ask a junior to do that for you. So I think that's definitely the key and the take-home message. So thank you very much, and we might draw that to a close.
Thanks, everyone.
Thank you.
If you have any suggestion about any future webinars, please send us a note.